I am Dr. Ramesh Gajula, endoscopic spine orthopedic surgeon and interventional pain physician. I am going to give you a brief note about trigeminal neuralgia. As an orthopedic surgeon as well as a pain physician, we do get a lot of this trigeminal neuralgia being referred to us by the neurologists as well as neurosurgeons for radiofrequency ablation of this trigeminal ganglion. As such, the trigeminal neuralgia is a typical electrifying or lancerating type of unilateral facial pain which is severe in intensity. Initially it comes in short bursts, but as it progresses it is like a chronic pain disorder. Patient do have suicidal tendency, that is the gravity of the pain. Coming to the epidemiology, usually it is most commonly seen in the females, and usually it affects above 40 years and 50 years of females. Usually in the beginning stage it usually affects V2 or V3 component of the trigeminal, but gradually it may progress to involve all the branches of the trigeminal ganglion. So this is all about the epidemiology. According to International Headache Society, there are two types of trigeminal neuralgia. One is classical, the other is secondary trigeminal neuralgia. In classical trigeminal neuralgia, majority of the patients suffer from this, and in that, one of the reasons for the trigeminal neuralgia is the superior cerebellar artery at the root entry zone. There is a neurovascular conflict because of which patient may present with severe lancerating unilateral headache, facial pain. So this is how is the presentation of the trigeminal neuralgia. There are some secondary reasons for which patient suffers with trigeminal neuralgia. One is the tumors, the other is so-called multiple sclerosis, wherein we rarely see bilateral trigeminal neuralgia symptoms. If you see the disease progression, initially there is a component of remissions followed by exacerbations, but in due course of the time it is continuous pain which becomes a chronic pain. There are no more remissions in case of trigeminal neuralgia. If you see the anatomy, this trigeminal ganglion is formed from the trigeminal root which comes from the brainstem, and from the trigeminal ganglion which is stationed at the Meckel's clave, it divides into three branches: V1, V2, V3. V1 is nothing but ophthalmic, V2 is nothing but the maxillary, and V3 is mandibular. So V1 ophthalmic branch, it comes out of the superior orbital fissure and it finally terminates as supraorbital and supratrochlear nerves. These ophthalmic branch is more or less, it is a sensory branch. And coming to the V2 component, that is maxillary, it comes out from the foramen rotundum and it supplies almost the area above the upper lip, including the upper lip, up to the nose area, nasal area, and just below the lower eyelid. And the third branch is the V3, that's nothing but the mandibular branch, it's a motor branch, and it terminates finally as infraalveolar branch nerve as well as mental nerve. So it is more or less, it is a sensory as well as motor branch, and we make use of this motor branch for motor testing when we are doing a radiofrequency ablation. So if you see the anatomy in the Meckel's cave, this trigeminal neuralgia is bounded posteriorly by the brainstem, medially by the cavernous sinus, and laterally by the temporal bone, and anteriorly by these three branches. Trigeminal neuralgia commonly involves the V2 component followed by V3. Sometimes V2, V3 is also combinedly involved, and V1, the ophthalmic branch, is very rarely affected. Usually when a patient comes, we diagnose based on the clinical symptoms. Always, even we send the patient for MRI to find out the neurovascular conflict. In case if there is a neurovascular conflict, then depending upon the age, the treatment protocol changes. Coming to treatment, usually the medical management is the first priority, which is done by most of the neurologists. They subject the patient to either carbamazepine or phenytoin sodium or baclofen or some gabapentinite type of drugs. Upon attaining the resistance to all these medications, a neurologist sends the patient to either a neurosurgeon or a pain physician like me for two reasons. So if the patient's age is below 50 years, and patient has got a neurovascular conflict, the better option is MVD, that is microvascular decompression, wherein they put a Teflon sponge between the vessel and the ganglion. This is done by a neurosurgeon. And the second option is above 50 years patient, even the patient has got a neurovascular conflict or no conflict. The treatment modality is not surgery, because above 50 years, again working at the brain stem, there are certain amount of complications. So if the patient gives resistant for surgery, then we opt for radiofrequency ablation. Non-invasive procedures, we have 3 to 4 techniques. One is injecting a glycerol injection, the other is a balloon compression, the third is a radiofrequency ablation. So every procedure has got its own benefits and some side effects. The only problem with the radiofrequency ablation is the numbness. For example, if you are doing a V2 component, if you are doing a V3 component, there may be a numbness. If you are doing a V1 component, there is a probability that has to be explained to the patient. And coming to the balloon compression, the only problem is motor deficits. And the glycerol injection, the efficacy part is little lacking with regard to glycerol injection. So at Panacea Spine Pain Ortho Center, let me show you a patient. She is a 70-year-old female patient suffering with V1, V2, V3 component. She has been bombarded with all the conservative medications by the neurologist, and she has attained the maximum dosage which a neurologist can put. Now they have sent to us for radiofrequency ablation. So let's go into the theatre to see how we are going to perform the radiofrequency ablation under fluoroscopy. What is submental view, what is caudal 30 degrees tilt, what is 10 degrees ipsilateral tilt, and how to see the foramen oval through which the radiofrequency needle gets into the Meckel's cave. So that is what, let us see all these things in the operation theatre, the position, the fluoroscopic images, as well as how to double confirm by doing sensory as well as motor testing with radiofrequency ablation machine. So let's get into the theatre.